very much. So many topics is very short. I will try to do the basics, and thank you very, very much for inviting me to this course. So this is a table of my content. I will start by saying that foot ulceration develops with a combination of peripheral neuropathy, peripheral arterial disease, and deformity. And in case of peripheral arterial disease, diabetes mellitus has a particular atherosclerosis distribution, meaning that calcification and obstruction of vessels will be more severe in the distal part, below the knee. The peripheral arterial disease is classified or recognizes two classifications, Fontaine and Rutherford. Rutherford brings something new, compared to Fontaine classification, brings objective criteria that are connected to clinical description of the disease. For example, mild claudication shows what kind of, in Rutherford classification, shows what kind of pressure do we have to find in order to classify that stage of disease. What is very important is that when we find a patient with peripheral arterial disease, that means that that patient has a high possibility to have atherosclerotic disease in other territories. So looking at the patient with diabetes and peripheral arterial disease, we have to look at his coronaries, because if we take a look at this excellent image that is in the guidelines of the European Society for Vascular Surgery that have been published in 2018, almost 70% of our patients may have coronary disease. So we have to take a look also to other parts of the patient. They are very high risk patients. We all have learned this during our medical study. I will not go deep in that, but they connect to the topic of my talk. They connect with the degree of the values that we find when we do the diagnostic tools. What is very important is that peripheral arterial disease is, the diagnostic can be done clinically. As many previous speakers have shown, we have to take off the shoes of our patients. We have to look at their feet. We have to palpate the pulses. But in order to establish the diagnosis of PAD, we have to perform ankle brachial index, toe brachial index, and to do a duplex ultrasound that is very easy to do. Who should have an ABI? The patients with clinical suspicion for lower extremity arterial disease, patients at risk for lower extremity arterial disease because of ischemic comorbidities. If we go back here, if we find a patient with carotid stenosis, probably 1 in 5 may have lower extremity arterial disease. Is the same thing with patients that have coronary disease. And patients that are asymptomatic patients for PAD, but are at risk, meaning that they might have diabetes or hypertension or hypercholesterolemia, or are smokers, or all of these. The guidelines of the European Society for Vascular Surgery recommend ankle brachial index as first-line non-invasive test for screening and diagnosis of lower extremity arterial disease. How to do that? We have to to invite the patient to have a rest for about 5 minutes, and then we measure with a Doppler probe, with a continuous Doppler probe, the anterior tibial artery, the posterior tibial artery, and we compare these measurements with the brachial artery. The Doppler probe should be inclined in order to get the Doppler effect. And this is the way that we calculate the ankle brachial index. It is the highest pressure among these two. That is at the upper part of the fraction, and in the lower part of the fraction, we have, in the denominator, we have the highest brachial index that has to be taken in both arms. This is very important. How to interpret it? The normal ABI, it is between 1 and 1.4. Above that, it means that the arteries below the knee are calcified, and probably we have yielded or obtained an overpressure, a pressure that is falsely high, and below 0.9 it begins the peripheral arterial disease. If this fraction is below 0.5, we talk about critical ischemia. That means that we have to do more in terms of diagnosis in order to identify the severity of the peripheral arterial disease. What is also very important is that minimal ankle pressure for healing an ulcer is 40 millimeters of mercury, and that has been stated in the guidelines of the International Working Group for Diabetic Foot edition, the last edition, 2019. As I said before, over 0.5, 0.3, 0.4, there are false negatives due to calcification. Why is important ABI also? Because when we measure interarm, when we find in our patients interarm difference in systolic blood pressure, that means for every millimeter of mercury, we have 1% of increased 10 years mortality risk. And also ABI below 0.9 doubles the 10-year risk of cardiovascular events and death rate. If we have patients with such calcifications, then we have to do toe brachial index. And these are the numbers. For PAD is below 0.7, so we have 0.2 difference to ABI, and the critical limb ischemia is below 0.4. Again, the threshold minimal toe pressure to heal an ulcer is 30 millimeters mercury measured at the toe. What about duplex? I have 30 seconds left. What about duplex is indicated as the first-line imaging method to confirm the lower extremity arterial disease. This is a normal aspect of a duplex ultrasound where we have the color and also we have the pulse wave Doppler. If the stenosis is below 50%, then we have almost normal waves. If the stenosis is somewhere between 50 and 75%, then we will have this aspect of biphasic waves. And if there are many stenosis and they are over 75%, then we will have monophasic Doppler waves. What about probe-to-bone test? Osteomyelitis is present in about 20% of diabetic foot ulcers, and the importance of probe-to-bone test is that if we make this test, but we are unable to probe a bone in an infective foot ulcer, that rules out the osteomyelitis with pretty great precision. And skin and bone biopsy are very good for infection diagnosis, are much better than taking a swab, and they are also very good in ulcers with high amount of exudate, with erythema and edema, and also in ulcers that are emanating different odors after cleansing. Thank you very much.